everybody. A lot of people entering. This is an amazing day. I think we're going to have a lot of fun and we're going to learn so much. But also, we're going to understand that in this kind of setting, we can learn a lot. And this is an interesting setting to learn, especially today with this amazing panel. These experts are from, another planet. So we're going to have a great time. Another episode from Stop at Nothing. This is webisode number 3. So for those who are not familiar with the concept, it's an online connection with the audience. We have an expert panel. Then we have a hands-on demonstration. Is one of the most important things we have. Active engagement. So please ask. Please, it's very important. This is for you guys. So everybody, I want that chat on fire and talking and talking and talking. And then this content is going to be on demand. Okay. I know it's kind of late. We changed it time. It's kind of late for Argentina, Brazil. Thank you, Milton, for being here with us. We know it's late, but we're going to have a lot of fun anyways. About what happens here, and I'm obsessed with this new methodology to teach and to learn. It's something called deep learning. It's about critical thinking, problem solving, everything that's going to happen today. Second is the environment you learn and teach. And this is the environment is amazing to learn and to teach because, we're surrounded with the instruments, with the eyes, what's going on, the movements, how difficult they are. And third, this is learned focus. So this is for you. These are going to be simple tasks. Maybe for some of the, for example, for Yamane, we're going to do a couple of steps. But what we want to tell you is that you can learn a lot with this. We have Yamane Lebevsky with us here, and it's a pleasure to have her with us because this is academy and industry working together. We have a lot of resources here to do this thing we love, and it's industry and academy, working together. So Yamane, it's great to have you here. I don't know if you have some words for us.
Thank you so much, Ivo, and thank you for the opportunity to partner with you and everyone at Ophthalmo University. What you and your team do is really incredible. I love seeing in the chat where everybody's from, all over the world. Your programs are really designed with the surgeon in mind. Love the Phaco Mentors group, the Refractive Mentors group. It's just great. We have such an amazing panel today. The last 2 weeks, today, and the next couple of weeks. I'm really excited. We can't wait to learn. And just from all of us at the Alcon Experience Academy, thank you so much for the partnership. We really appreciate it. We're ready to learn.
Oh yeah, today is going to be a great day for that. Well, let me introduce the panel. Actually, I don't know if they need introduction. We're going to name them because these guys are amazing surgeons. And today they have a difficult task that is to teach, right? Because something is to be a good surgeon. Another thing is to teach and to communicate that. So Ike, it's a pleasure to have you here with us. We know it's late. You have a lot of things and it's cold there, but having you here, it's such a pleasure. Milton, again, amazing surgeon from Brazil. Great to have you here. We know it's late down there, but you're here with us. Thank you, Milton. And Luz Marina from Colombia, also a pleasure. She's just part of Ophthalmo University, always with us, and an amazing surgeon. And so again, guys, Phaco Mentors, Ophthalmo University, present in any social media, and just can't wait for the next one. Next Wednesday, we're going to talk about toric IOL speed, and in this setting, we're going to do surgery, we're going to do calculations, and we're going to go from something very technological to something very simple to demonstrate that everybody can master the torics with or without technology. We have Kathleen McKevy is going to be great. Juan Manuel Paulin from Mexico. Cesar Vilar is here today translating and is going to come to the other side with us. So it's going to be a great experience as well. Okay, guys? And let's start. I want to show the least number of slides as possible, and we're going to come to here where the magic happens, okay? But we do want you to go for tomorrow when you go to the OR with more skills, more knowledge, but especially critical thinking, how to do decisions inside the eye, how to plan. There's many interesting things happening. And for that, we have planned 4 cases. We're going to discuss a little bit with the panel, and we're going to have 4 cases. Small pupil with a hard cataract, that's going to be for me. Iris suture for this amazing surgeon next to me, Dr. Jose Ramon Ponce here from Mexico, a great friend, great surgeon as well. Weak sonula, and we're gonna do a Yamane just to finish so you can understand how you can learn Yamane, outside the operating room. And this is one of the things I love, right? I want people to understand that when you are in the OR like me with a resident there, it's a very stressful situation, but not only for me, for the students as well. And I want to ask the panel if they think, I agree that there's many things you need to learn in the eye because you need to understand the consistency, the tissues. But what about what's going to happen here? I want to make you think. We have a couple of questions for the audience. Lisandro, let's hope we can put some of them. But the OR can be sometimes, as you can see, a high pressure environment where patient safety is imperative and the time is also an issue. So where is the best place to learn, right? I'm gonna leave that question out there for you guys. And then I'm gonna ask this amazing panel. I'm gonna start with Milton. So what do you think, Milton? We're talking about complex cases in this case. Which is, which are the items or the concepts we need to master in order to face these complex cases?
Well, good evening, everyone. I'm very glad to be with you guys. And regarding this question, I mostly stress out the importance of you have domain of the fundamentals, because all these aspects, strategy, planning, confidence, and measured feedback are important. But usually I see so many in development surgeons that think that learning is to be done during a real surgery. And they disregard some studies on fundamentals and especially simulations. So I think some things come before these 4 key aspects, and it is something that I value so much, which are the fundamentals. So having control of your equipment, of the parameters, of the technique, and everything else, which is very theoretical, is of the greatest importance.
Excellent, Milton. Luz Marina, a great surgeon, always facing complex cases. You master Phaco, you master extra cap. What do you think we need to master in order to face complex cases?
Okay, one thing that I think that's very important. Thank you first. Thank you very much for being here with us. I enjoy being here and sharing everything with you. So nice. Well, the first thing I think you should always be very self-critical. Knowing yourself, remember, is the beginning of wisdom. And it's important to know what you know what you have, know what you can do, know what you can't do, and prepare for yourself for the things you can't do. Also, it's very important to keep in mind that you have to keep, we teach principles, we teach facts, we teach processes, and the concept of having principles also, it has to be included. It has to be included because within all this that we've been talking about of having this mindfulness, this critical thinking, this knowledge, and these skills, you have to have the principles of honesty, the principles of keeping in mind the safety for the patient, and to do what's best without harming.
Excellent concept. I love principles. I think, for surgery especially, they're very interesting. Ike, great to have you here, and I'm pretty sure you have amazing concepts about this.
Well, hey, listen, thank you so much for having me here. What a great group of panelists. And I'm worried about Jose next to you. I think he's a little bit sweating. He's a little bit worried. He looks so relaxed, though. I mean, that's the ultimate surgeon.
That's where we go. Exactly. Yeah. Next to Ivo, anyone is relaxed.
He has a hard job today.
It's a good thing that patients won't be moving around today. But I think you say it very well, and I think everything you teach at Ophthalmo University is so important. And the first thing I always say is that let's talk about outside the eye, right? The action in the eye is really started from what happens outside the eye, and even before outside the eye starts with our imagination and our visualization. And I think that's the part in preparation for these cases that's so important, to visualize and imagine the steps as you go through with your hands and the fingers and the right instruments, I think, are so important. And then the other aspect, of course, is, and I think I heard about principles, as we heard, of course, from Luz Marina as well. I mean, understanding fluidics, understanding the laws of physics, working in closed systems and using the fulcrum of our incisions are so important. So, I mean, I think we're going to see more about this, and you're going to hear about this today. But I think, and one of my favorite things, as you know, is complexity, simplicity multiplied, because we can really break these complicated things down into simple steps if we can think about them ahead of time and follow the physics of the eye and the fluidics to make things happen. So just some brief comments to get the ball rolling, but thank you.
I love that, and we're doing, a quick voting because, we are talking about excellency all the time. We're talking about how to be competent, and there is many people that they don't have a chance to train in complex cases. We can see there that almost, if you sum that, it's like a 77% that of not at all or some cases. So they don't have the option to train on complex cases during residency, and then when are you going to do it, right? With private patients, it's not easy. And I want to go back to the last concept you were talking, Ike, and this slide was just designed for you. You say that complexity can be deconstructed, right? And we can see you every time you're doing even live surgery with these complex cases, you're just planning, you're just visualizing. Tell us a little bit more about that.
Well, on one comment on the poll you mentioned, and like many of us in residency, we don't necessarily do lots of complicated cases, but it's important to do routine cases with the best technique. And I mean, in University of Toronto, for example, we train our residents, they do like 400 or 500 cases or more in residency. But the training and doing it is not necessarily the same as translating that into complicated cases. And so doing the routine case perfect, meaning the eye doesn't move, meaning that all the motions in the eye are done with the right ergonomics and the right efficiency and the right fluid nature of them, using the least amount of effort to do the work. Instrumentation shouldn't even move in the eye. Things come to the tip. I mean, all these things you can do even if you don't do complicated cases. So approach a simple case as a complicated case and perform each step perfectly. I'm talking about even the microscope being centered, the focus being perfect, the zoom being more appropriate for what the step is. So that's the first thing. And absolutely, I mean, I think this is a nice little diagram you have here, that complicated things can be deconstructed, can be untangled as per your picture into discrete, simple steps. Like cataract surgery, for example, each step is a simple step. To someone who's never done cataract surgery, it looks very complicated, but most of you do cataract surgery because you can put together the steps together in a simple way in that sense. And then, as you said, the next part is doing it elegantly. So our challenge for those of you that are doing routine cases and not necessarily lots of complicated cases, do the simple cases elegantly, and that'll bridge you toward moving toward complicated and more complex situations.
Amazing. I love that concept. Let's try. There you go. And what I also like, in my opinion, I'm obsessed with this concept about deconstructing surgery in three main areas: the motor skills you need to have, to do microsurgery, but also the algorithm to make decisions, the problem solving, and also the mindset. The mindset you're gonna have in the entire case, before the case, how you prepare, how you're calm no matter, even when things don't go the way you want to go, right? That's something very interesting to master. And we talk about this algorithm. And Milton, we know you are very, it's very important for you when you're doing decisions in a complex case. Tell us a little bit more about this algorithm to make decisions.
Well, I think, for example, whenever we think of regular phaco surgery, as Ike mentioned, there are multiple steps, multiple data that unbelievably most of surgeons don't rely on, like the energy spent on specific surgery, or the amount of BSS, or so many little things that you don't measure. So everything that you don't measure, you cannot improve. So this is the importance of such an algorithm in which you can have a workflow to really see the improvements. I've heard a repeated saying here that perfection is something that you do repeatedly, but I don't believe that. My wife drives for about 20 years, and she drives the same way. It's repeating something. You may never achieve perfection by repeating something. Repeating something is a very complex process. And even things that you supposedly know, for example, like I mentioned, the microscopes. So many doctors don't know how to operate the microscope in its inner workings. So many setups in the microscope. So sometimes we buy a Ferrari. We have enough money to buy a Ferrari, but we don't know how to drive it. So this workflow in terms of decision making is very important, but you have to make it work. It won't work alone. It won't work on a paper or in this slide. You have to make it as a habit.
They say that only perfect practice makes perfect, right? It's not just practice. Grab a ball and shoot the hoops. It's about the deliberate practice, what it's planned, right? I think that's a very interesting concept.
My wife is sleeping already.
Luz Marina, tell us a little bit more about the mindset. We know you're very into the mindset, how you prepare the day before the surgery, how you face complications. Tell us a little bit more about this.
Well, yeah, thank you. Well, I think that also it's like an artist when it goes to a stage. They have to take a look at everything. How's the scenario? How's the weather? How is the audience? How's the sound? How's everything? So you have to be analyzing every step that surrounds you, not just the ones you have, but everything that's around. And I think that Aristotle, I agree with him when he said that excellence is never an accident, because it's the result of high intention, sincere effort, and intelligent execution. It represents the wise choice of many alternatives. Choice, not chance, determines your destiny. So I think that it's true what Ike says, that things complex, if you know them, if you have the way to get them, you can make them easier. And just going step by step, improving in your skills and being honest with you in what you can do, it will give you and it will allow you achieve to manage complex cases. Also, what's complex for you is not some complex for someone else, because as time goes by, things that were complex for you maybe 5 years ago, right now they're not. But that's not for free. That's not granted. You have to work in it hardly in every aspect, and you have to also see surgery and to know and to learn and to make yourself improving constantly.
Very, very interesting. And we were talking about this. We were talking about planning. We have seen Ike before, live surgery, just, in the environment, owning the place, everything needs to work, making a couple of jokes, planning, even the just little small, details about that case. And also, this is true, in his YouTube channel, we can learn so much. Tell us a little bit more about this planning concept, Ike.
Yeah, I think, I want to just mention one thing. I mean, we have great people here on the panelists and many people are watching. And I want to tell you that I can tell you all of us, particularly myself, we're like everybody else. I don't look at myself as being anything special skills or superpowers than anybody else. So the stuff that Ivo and Ophthalmo University and others and Phaco members have been talking about are really things that everybody can do. I sincerely believe that. What it takes is, though, as you heard earlier, is that courage and confidence and that approach that I hope that we're talking about today. And yes, I mean, no question that planning is critical for any athlete going into a big game. It's critical for any, speaker. It's critical for a surgeon. And that preparation now is so much at our fingertips with so much knowledge and data out there. And I mean, I think that the best experience, of course, is getting hands-on. I love the idea of artificial eyes, but certainly surgical videos have made it a lot more accessible for everybody to get. I think the challenge is we have so much out there, it's hard to know where to go. And this is why I think, these venues are important to be able to know what's important.
Mm-hmm.
Excellent, excellent, amazing concept. And this is an amazing, I actually was thinking about IQ when I was thinking about this slide, because this is one of the most extreme sports in the world. People die with this, right? But I think it's a question. I don't want the panel to answer now, but I want them to answer in every case, right? Which are the limits? Because some of the people were saying you always need to know your limitations. But what if we just sometimes we do a little step forward? But I'm gonna leave that around, and then I'm gonna ask the panel in each case we're gonna face. This is an amazing colleague, David Lockington. He's sleeping because he's in UK, but he talks about how we can simplify complexity also, to have everything we need to plan and to have everything ready, everything that surrounds us, not only instruments, but substances or even a good team around you. I'm gonna go fast then, because then how we train with complexity, how we train to complexity, where you're gonna see that now. Always talking about the movements, the decision making, and the mindset. We invite everybody, in Phaco Mentors, this community that is growing, and we wanna, invite everybody just to discuss cases. And this is what's gonna happen now. Now the fun starts, right? We're gonna see 4 cases, but you're gonna have cameras surrounding us. You're not gonna see what happened in the microscope. I want you to ask. I want the cameras to surround us. We're gonna have a small pupil, hard cataract, asking the panel all the time what they think about. We're gonna do some iris suture. We're gonna do weak sonula and scleral fixation. As you know, we were talking about with the panel that we could talk 2 hours about each single area. But in this case, we just want to go fast, and we want people there to understand that this is an amazing place to learn this kind of thing. And second, that we can go fast and show some things, and then we can come back and do many, many more webinars about it. So we're going to start with small pupil head cataract, and you guys are going to see just one case for Luz Marina. This is a very, very fast case. And then we come to our operating room, okay? So Luz Marina, let's start the video, and you can talk about it.
Okay, this is a 83-year-old male that he was receiving tamsulosin with an anterior chamber, a shallow anterior chamber of 252, a hard cataract. See, you have to watch for the thickness of the lens. That's something you have to always consider. It has a small pupil and an endothelial cell count of 1800. The informed consent, it's always present. So we begin with a paracentesis, we make some dye, some stain, some viscoelastic. And so anything change, adrenaline, viscoelastic, and still the same. So you have to consider, do I place some Grit-Haber hooks? Do I use Maljugin ring? What do I use? Or can I manage without them? So I decided in this case to use some stretchers just to get rid of a good, at least a good pupil for a capsular rhexis, because something very important is to have a good size of the capsular rhexis. The worst thing that can happen to you is to have a small capsular rhexis. So I was able to achieve a good capsular rhexis, and then afterwards the pupil again was small. I made a central pit, and then I introduced a sustainer. I'm going to introduce the sustainer in this way. So introducing the sustainer with the left hand in the equator of the lens to lift the lens, and then with the ultra chopper, I'll break up the lens into as many pieces as you want. It's very important because in hard cataracts, ultra chopper is very useful to break and make these fractures. And then since it was very rubbery, I have to finish maybe with a little bit of pre-chopper to help yourself improving the fracture. Then when you are already, all the fractures done, is complete, then you go with the torsional, with a Phaco tip, the balance tip. Right now we have the new Phaco tip of Falcon. But and then we're using the torsional, setting it with 40 at least, 40, between 40 and 70, using burst to keep the CDE very low. And so we finish the case. You can see the pupil right now, it's very, very small. But if you keep in the center, you can manage. But if for you, it's easier to place the Grishaber retractors, the Grishaber hooks, do it, because you have to make yourself things easier for you. So keep in mind that you have to do what you're prepared to do. Consider the elements that you have available and make yourself things easier for you. Keep Phaco chip in the center and be patient. And concerning the limits, well, I agree with Buzz Lightyear in Toy Story that he says that the limits are to the infinity and beyond, but you have to prepare for them. Thank you.
And I hope you can see with us. Now they're gonna surround me with cameras. Let's see, let's stop sharing the slides, please, and let's ask the people if they, if they feel confident about these cases. Okay, so I'm here in an amazing setting. Let's see if you can see me from here in this camera. I'm surrounded with all the materials I need, like I said, right? Also putting the microscope in the correct setting, having an ingenuity there, watching in 3D. It's an amazing thing. You can visualize more details, you're like inside the eye, right? You're working, and it's an amazing feeling. And also I want you to see everything that's happening. Please also the panel interrupt me at any times. What I'm gonna do is I'm gonna do an incision, put viscoelastic, put a couple of iris hooks, then an expansion ring, and we're gonna discuss about these limits, when I need to put a hook, when I need to put an expansion ring, when I can go and do Phaco. Is that the same for Ike versus the first year residents, right? Is it the same decision making or not? It's very interesting about the results. There is a 50% of the people that are somewhat confident with complex cases. That's very good. But we also believe that, you can always learn something new from somebody else, right? So this is, I think, is going to be a lot of fun. So let's see if you guys can also see what's happening in the microscope. Let's see if the audiovisual team can show the microscope to me. Let's do a picture. There you go. You can see the eye there, okay? And you're gonna, I didn't put this scholastic yet, so you're not seeing correctly. But I'm gonna do an incision the way I do it. I like to mark the cornea first. And I would love to do a 3-plane incision, right? This is important. I always talk about this reflex that needs to be uniform in order to have a perfect architecture. Then I do here, see this, I do a second plane here, and then I rectify again, and the in and out, okay? In and out. Don't go to the sides because you make the incision a little bigger, okay? We're gonna put some viscoelastic there. I also love to put viscoelastic in a certain way that I go far away and then I come just taking everything apart. Can you guys see that eye? Hope you can see it. I see it wonderfully, perfectly. And you can see an iris that I would like to ask the panel. What do you guys think? Would you put iris hooks? It looks big, right? What do you think, Ike? What is your decision making when you face a small pupil? When to go one way or the other?
I think one big thing, of course, is this is potentially a floppy iris, because we can start with a big pupil, which can come down. So that's one factor that plays into it. If it's somebody who is on a previous alpha blocker or on it, then that may be more likely to place a device for those certainly that are starting.
Excellent. What is your opinion, Milton, about, how many hooks do you put? Which is the shape you like? We recently have a couple of videos of Thomas Oetin putting one hook behind, I don't know if that's correct. You correct my English, but behind the main incision, so the iris is not, complicating things. What's your opinion on that, Milton?
Well, in terms of the incisions, I prefer to go the reverse way. I prefer to do the smaller incisions first, depending on what you're using. If you're using just your left hand for your chopper or for a hook, or if you're using the iris hooks like you're using now, I prefer to do the smaller incisions first, and then the last incision to be done would be the main incision, because I find it much more easy to perform the smaller incisions with the tonus of the eye.
That's a very good question. What about doing the incisions, the paracentesis for the hooks without viscoelastic, so you can stain the capsule? What do you think about that, Luz Marina?
Well,
do you do it
no,
before, after?
I prefer to stain the capsule, and then afterwards, no, then the main incision, and then afterwards the paracentesis for the hooks.
You sorry, I didn't catch you.
No, that I prefer to do first, do the stain, then wash out the stain, and then introduce some viscoelastic, then do the main incision, then the paracentesis and the small incisions for the hooks, the way you're doing it.
Perfect. What about you, Ike? How many hooks do you put if you have to put them?
So a couple of things I just want to mention. I think you were referring to Tom Oding's diamond configuration for the pupil, as opposed to the classic square. And I think that's a very useful approach, because it keeps the subincisional iris away from the incision that will be otherwise tented up, because the iris hooks tend to bring the iris more anterior because the hooks are coming from the cornea. The other thing is, when you put the hooks in, avoid making a long tunnel. Make them short. In fact, we usually like to make a long corneal incision for our typical paracentesis, but this, I would recommend, make them steeper and small, because then the iris hook is going down toward the iris rather than across the anterior chamber. I noticed your incisions, if I may say, were more planar with the cornea. And for the iris hook, it's better to make them less beveled and more perpendicular for that reason, because then the iris is going down, the hook is going down toward the iris. For me, I like to basically actually do my viscoelastic, place the incisions, place the hooks on, and then I put my trypan blue, if I need it, by painting it, not injecting it, painting on the anterior capsule. And that way I don't need to basically irrigate it out. That's what I typically do.
Excellent. So when you're talking about perpendicular, I agree. It's not very planar, but just deep, so you can grab the iris, correct?
Yes, and I want to mention that these eyes are fantastic. Bionicle makes great eyes, but of course they don't behave like a human eye. So there are a little bit more resistance with the incision. So don't fault Evo if it's a trouble to get the iris hook inside.
All the mistakes I will do is just in purpose of education, right?
Yes, of course.
It's not me.
Yeah.
That's what the good surgeons do, right?
They're fantastic. I hope everybody gets a chance to learn artificial eyes. They're the best way to learn for these complicated cases.
For you guys to understand, we can put an expansion ring. We can talk for hours about this. This is actually an eye ring we're using, and again, I just want you to see how it behaves, how you can, work with this in the anterior chamber. Again, when we talk about simulation, there is something called fidelity, and there is many things that are the objective with simulation. And the objective with simulation, it's for you to at least, for example, in this case, to work in an anterior chamber, to see in 3D, to have movements, and remember that here is the endothelium, right? And he's gonna remember you, and there you have a hard cataract. So that's what I want to teach you. Yes, there's many people that say, well, is it realistic? Isn't? But that's not the discussion when we're learning. Okay, so I'm gonna move fast because I just want to go. Look at that. Look at that beauty. We're putting an eye ring. We could put a maluin. We could put hooks. We could put many different things, and then I can keep going and making decisions in doing a hard capsular rhexis. So again, I didn't get the limits when you have a small pupil. What is your opinion on that? When you draw the line?
So Luz Marina said it perfectly. I don't really worry about a small pupil. I worry about a small rhexis. If I can get a good sized rhexis, I will be honest, I don't mean to show off. I rarely use any iris hook or any rings. I mean, I can phaco through a 2mm pupil as long as the rhexis I made was at least 5mm. So that's kind of what I do. If I cannot make a 5mm rhexis, then I will put hooks and otherwise. But usually you can do a rhexis under the iris or use the hook to do it. But I recommend for most people, be comfortable, do what you feel comfortable. And I think once the pupil gets below, 4mm, it starts to become uncomfortable for people. And so if you can, that's a reasonable limit, but that's it's all subjective to what your own opinion and what your comfort is.
I love that. So what you care about is the size of the rhexis, not the size of the pupil. Bilton, any thoughts on that?
Well, I completely agree with Ike. Some small pupils don't need to be expanded, but it's very important for you to use the right technique when confronting with the nucleus, because you have to be very skillful in terms of your technique. For example, if you do use apprehension like high vacuum, you have to be very skillful, because you will have very little space in order to apprehend the nucleus and use your left hand with the chopper to divide it. So it is something that can be done, but it relates especially with your ability with the fundamentals, as I said. And there is a saying here in Brazil that one technique for a small pupil without rings or without refractors to perform a small pupil surgery is to act like it was a big pupil.
Very good
pretend
one.
it.
Any thoughts about that, Luz Marina?
Well, yeah, I strongly agree with Ike and Joggy, and something that I insist with the trainees is that you should learn, like in Karate Kid, remember the movie, to be blindfolded, to go like under the iris to achieve a good rhexis. And if you get a good rhexis, I don't use any other hooks. But if the problem is you have a small rhexis, then you get into trouble, because it will be very hard to manage. And if you have a hard nucleus, even more. But
that's key, Luz Marina. And what about the rest of the panel? I put on purpose a small pupil and a hard cataract, right? It's not an aspiration. It's gonna be, that rhexis you can see I did. It's pretty small, and we all know, right? Small rhexis, hard cataract, not a big combination. Okay. So let's start doing some hydrodissection and some phaco. What are your you can start, Milton. Which is your favorite technique for a hard cataract?
Well, actually, I have devised an instrument that you may be aware of, or at least most of the audience is aware of. It's like a wand, or it has support for the nucleus equator, and it's very useful for all types of cataracts. And it's the instrument I use in, I would say, 99% of my cases. It goes very well with soft or hard cataracts, and it goes, again, contrary to the common sense. I don't use the phaco tip first to embed it on the nucleus. I do otherwise. I place the support of this chopper at the equator of the nucleus, and then with the support, I go with the phaco tip and just crack the nucleus without using vacuum or US power.
Excellent. What about you, Ike? What's your preferred technique for a hard cataract?
So yeah, for me, I think the key point is we have to get a crack. Once we get the heminuclei formed and the nucleus split, we're basically almost there. And I find that is best and most predictable by doing at least some sculpting. I love chopping. I chop everything. But in a dense cataract, I don't want to see a leathery posterior plate. I like to do the A scan or biometry to look at the lens thickness. Once you start getting close to 5 millimeters, these can be very thick lenses. I like to groove very deep down to the posterior plate, either stop and chop or debulk and then chop. But I have to make sure I get down deep, and that means doing some amount of sculpting, because we don't want to fight with the posterior plate. Exactly as Leonardo said, debulk chop. That's what I like to call it too. And that is a sure bet to make sure. And vertical chop is beautiful for these cases. And again, going to small pupils, when you chop, I actually don't mind a dense cataract, because we should always keep our instruments in the central 3 millimeters of the eye anyways. If you draw a cylinder in the middle of the anterior chamber, the best surgeons, they don't move around to grab the pieces. They keep the instruments in the center of the pupil, and that's where they work. So whether the pupil is 3 millimeters or 8 millimeters, doesn't matter, because the instrument should still stay in the center of the pupil of the eye.
That's true.
Ike said something very, very interesting, because I really like it. We all love to chop, but in these cases, it can be a lot of stress of the sonula. But you said something about going very deep in the center, right? Because sometimes we have a lot of diabetic people in Latin America. They're very leathery. It's very hard to crack them. And I'm putting parameters. They're very, very aggressive here, because this is behaving like a very, very hard cataract. But as you can see there, I hope you can see let's see how you're seeing. Yeah, you're seeing a little bit of the, I'm seeing amazingly, maybe Zoom sometimes is bad with us, but I'm doing an amazing
You're doing amazing.
sculpting. I'm doing amazing.
Amazing, amazing job.
Okay.
Well,
We can do
I'm
the
gonna-
maneuver to crack. Look at that.
I want to tell you, well, my best approach for these hard cataracts and those issues will be solved is with the ultra chopper. The ultra chopper, you can work and it doesn't produce any stress in the sonula. You can break up hard cataracts, even though they're very rubbery, so that's something very advantageous. You can use it with a small pupil or with a small rexis even. And it's a very, very hard pupil. You can do also the cylinder in the center, because it acts like a bicycle spokes, that when you take up the center, then all those spokes just fall apart, and you can then grab those fragments easily.
Okay, I'm doing some chopping here just to talk about, chopping. I think chopping is an amazing technique. And I always love about this safety zone concept, right? Every time I do ultrasound, it should be far away from endothelium, far away from the posterior capsule, in a safety place, and always being efficient. I like to hear that machine. This is one of the most important things you guys can learn here, okay? To listen to the machine, right? I know you love this concept as well. How the vacuum is rising, and then I'm gonna go to position 3, very smoothly, so I do very effective ultrasound. What do you think about that, Ike?
Yeah, I think listen to the machine, listen to what's happening with the fluidics. It's very important. And use your eyes and all your senses as you're operating. And I think, for these dense cataracts, don't be afraid to use enough phaco power. I know people talk about minimizing phaco power, but in these cases, we need phaco power. Otherwise, you're going to stay in the eye for a long time, and the turbulence can be more traumatic to the endothelium than actually the phaco energy. I like to use the dispersive viscoelastic as well. But I think, don't be afraid to use enough phaco.
That's a very good one, Ike. Do you have a metric to say, okay, I need more dispersive? It's CDE. Is it time? What is it?
Yeah, I think I usually look at both. If I have a dense cataract and I'm going already close to 8 to 10 on my CDE, I will put more in to protect the cornea. So that's what I do during the case. I don't come out of the eye, just take my chopper out, inject dispersive under the cornea, carry on. If it's someone with Fuchs dystrophy, I may do it more frequently even, but viscoelastic can really be your friend, although I realize the cost can get more.
Good one. We are doing, this cataract is behaving as very hard. And again, students can come here, understand what it is to have a centered eye, 2 eyes in a very small anterior chamber, listening to the machine, synchronizing what's happening with the pedal, I think this is an amazing tool to learn. Any other thoughts while I'm finishing and we pass to the iris suture? There is many people waiting for it.
One thing that I used to try when I deal with very hard cataracts is sometimes I change the Phaco chip from Alcon for the Ortly Phaco chip, which has a very clever design for, especially for hard cataracts. The cataracts Phaco machine has a large bore chip, and it has a very efficient dissipation of its energy. So for hard cataracts, it's a very nice option, but you have to adapt it because it's not suitable for the Alcon handpiece. So you have to have a special uh, uh, tool to adapt it.
Okay, guys. So enough of small pupil, hard cataract. Let's go to something I think I likes a little bit, right? It's about iris suture, and we have the amazing Jose Ramon here. Let's talk a little bit about it. We can learn a lot in this kind of setting. We're gonna go with another video, and Jose Ramon is gonna get ready in the next
slide.
in the next station from me.
Yeah.
So please put the slides. Let's see a video from Ike, or maybe Ike, you can share it. Why don't you share it, Ike?
Yeah, let me share it so I can move through this. And I think when it comes to iris suturing, there are so many ways to learn, and I think it's good to know a few different tricks. I'm going to show you a very classical approach called the see-through sliding knot. This is, I think, something that everybody can learn to do. And a couple of points here. Number one, you'll notice that the incisions are made. I'm sure that Ponce will do the same thing. We're going to plan the incisions to ensure that these are long curved needles. These are not the short, quarter circle or 3/8 circle needles. These are long curved needles. And so take advantage of that by making incisions that are farther apart, and we can glide the suture into the eye. Second thing, you'll see that we're making sure that we don't grab the corneal incision when we pass the needle. Otherwise, the suture is going to get caught in it. And thirdly, look at the forceps. The forceps help to hold the iris. Now, we can use a hook, a gancho, but I do prefer using a forceps of some nature. And then to come out of the eye, I like to dock the needle to avoid, again, trapping the needle in the cornea. I know some surgeons will basically put the needle through the cornea. I prefer to make it through a paracentesis. I think it's just cleaner. Now remember, we have a distal strand here I'm pointing to here, and we have a proximal strand. Remember those two descriptions I'm just using here. Now, the second step we're going to do, or when we pass the suture, is to take a Kuglen hook, take a gancho, and bring the gancho into the anterior chamber and grab the distal strand. But make sure you have enough suture outside the eye when you grab it, and bring the loop into the same paracentesis or incision as the proximal strand. So now look, we have a distal loop on the left, and we have a proximal strand on the right, as I'm just moving over there. I'm also labeling them, number 1, 2, and 3. Number 1 suture is going all the way out through the distal paracentesis. Number 2 is coming from the iris on the distal side. And number 3, this is the proximal strand coming out of the iris from the proximal side. So keep the orientation. It's very important to keep the orientation to avoid twisting the knot or potentially causing a knot that's not going to lock. Okay, remember this: distal strand loop, proximal strand, 1, 2, 3. So now we're set in the right orientation. Remember to keep these orientations right. If not, untangle the loop. Remember, complexity, simplicity multiplied. We're just simplifying the procedure, which is otherwise potentially a complex situation. So now we will basically cut the proximal strand short, and we will take simply a tying forceps, and loop the tying forceps around the distal loop. Here's the loop we have, remember? And we're going to set ourselves up. I just did a small little trick there. I moved the suture over to this side so I can grab it easily. I then literally just loop the proximal, the distal loop around the proximal strand, like we were doing a running suture in some ways. And then we pull the distal strand to bring the loop along the proximal strand to the iris. Again, it's going to be helpful to watch this video a few times. It's on my YouTube channel if you like to kind of understand this better. Now we have the triple throw. We will now bring the loop again outside the eye. Remember to keep the suture long, so it's out of the paracentesis onto the conjunctiva, and then we can then lock the knot. Now, some of you know, of course, the fourth throw pupiloplasty, which I think is an option. You can do the same thing if you're doing a fourth throw pupiloplasty. You can do it 4 times. I like to do a triple throw and then do a locking knot. This is a locking knot, and you saw what I did there. I placed the curved tire now to do a reverse throw around the loop, come through it, and grab the proximal strand. And so I personally like to lock a knot. If I'm going to suture the cornea, I'm not going to do a 4-throw corneal suture. I'm going to do a triple 3-1-1 or 3-1 because the locked knot will not loosen. It takes an extra few minutes to do this, but I think it's worth it. Either way, the point is not how many throws to make. The point is using this modified Seepster sliding knot that I've modified his original description to make it easier. And finally, you see I bring the loop again out, and I will do a last throw. So now this is a single throw again to do it. Like I said, there are mechano suturing, which is a simple way. Maybe Jose Ramon will show this. There is the Seepster knot, and then there are techniques that we have called McAhmed, if you want to call that, where we use micro instruments to push the knot into the eye, which I do like. And here's a micro scissor as well. So I want to just quickly share that technique. I'm not sure which technique Jose will show, but that is one approach that we can use for iris suturing.
Yeah, and this is kind of complex, but in this kind of environment, I think we can learn a lot. Jose is gonna show us a little bit, and I want to show something fun. Let's see if this camera can follow me. You know, we have also a device called MicroRec, and you can be practicing in your own environment, and with this you're connected with another surgeon that is expert. Let's see because they see, there's another surgeon seeing a perfect image of what's going on and giving you advice. So this is all yours.
Thanks, Ivo. Okay, actually, what we're going to do is the Seepster knot, basically the same directions as Ike told us. I made this rudimentary model of an eye, so it's easier maybe to understand how it's done. So we already passed the suture through the cornea and capture the iris, which is represented by these two strands here. So I don't have a big hook, so I'm using one of my wife's knitting equipment.
Don't do what Milton did
knitting
today.
Equipment only.
Be careful.
She kindly lent it to me. So you already passed one. You have the distal one with the suture with the needle, and the proximal one. So you extract the loop from the eye using your hook. And as Ike said, you have to have all your strands organized in order to not be confused or have everything entangled. So what I do is be sure which one is it. You can pull it slightly, and if the iris moves, then you're holding the strand with the iris. So you can do a 2 or 3 passes. Here we can do only 1 or 2. It's going to be easier. And you can, at home, maybe try to do one of these models so you can practice. So once you pass it through the correct strand, you start pulling the distal strand out of the eye, and also hold the proximal one while it's being pulled. And you can pull even more. This is a really long one. It's just an example. And you can see the knot sliding inside the eye, and there you have it. So it's a nice way to understand how it's done in the big picture before starting doing it in a microscope. So it's easy to do. You can email Ivo or me, and I can tell you how it's done. So let's I don't know if we can start here. with the bionic eye. So we already had, as Ike said, 2 paracenteses. Important thing to do is do it, as Ike said, in the direction of the needle that's going to enter in the eye. So it's done here. Another one is done the opposite direction to capture the needle. In these eyes, it's important to tell you that even if you do a correct paracentesis, the needle may be stranded in some of the fibers of the plastic that the corn is made of. So I'm gonna do a double capture of the needle with a cannula, so we don't have any trouble. So we are using a straight needle of Proline 10O, and I tried to make it a little curved, so it's going to be easier. That's the one. That's because that's the ones we are available in Mexico. So
This will be on sale soon. The Ponce needle.
the Ponce needle, yeah, it's like the crooked one. So I told you this is a difficult paracentesis. So it's a good idea here if you're going to practice here eventually or you're using this size to have a double capture of the needle because of the material I already told you. So you can dock it outside the eye.
So you see, this is a clever idea, because even in a human eye, if you pass a needle and you grab the corneal fibers, like the posterior lip, yep, it's game over. You cannot release it sometimes. So this is a clever technique to do them. By the way, those that are using these model eyes, make your paracentesis bigger, just because it's hard to get through these plastic eyes. You can make it easier to work in.
Exactly, I agree with you also, and a bigger place to work. So what you can do is this eyes, actually the iris is kind of like a cardboard, so it's easier to go through. This is our defect, right? So go before the defect, and you can bend a little bit your needle and pass to the other side of the defect. If you are in a real eye or a different model, maybe try not to do it. Use Bionico. You can use your micrograsper like Ike to pull your iris and help pass the needle through the iris. This is helpful, but so you won't be pulling the iris and causing more inflammation or any more lesions. So once you pass through the lesion, you pass the needle again into the cannula, and you can extract the needle through the other port. And actually, this is in this kind of eyes is kind of easy. And real life can be tricky, but with practice and good practice, everything's possible. So once you pass it, you pull, as I told us in the video, and be sure you have enough suture on the other side. You don't want it to pull it all over and have to start all over again. And I think this is quite good. You can use the coolant hook. I don't have one, so we're using. You can use a Cybele maybe. Or if you have microforceps, you can use them too.
A gancho, hombre. A gancho.
Gancho.
Gancho, man.
Gancho.
Gancho, yeah, gancho.
El ganchón. Okay, so you extract your all your strands, and it's here it's more difficult maybe compared to the model to try to identify all the strands. So I pull them. So you see one of them is in the iris, through the iris is this one. So you want to use, you don't want to do it. So you can use your maybe this McPherson, or I use a micro tire. It's easier. So you can pull it. You can do the 3 passes. I like to pass it through the loop like this and do the 3 passes. It's kind of tricky
guys,
sometimes.
I just one comment. Please watch what's happening outside the eye, right? I was saying that I think it's very important. You know, you see the YouTube video and okay, yeah, it makes sense, but the magic it's outside the eye. And here you can watch, you know, his hand position, the movements, all the instruments he's using. I think there's very, very important things happening outside the eye you can see there.
Yeah, and also I use a temporal approach, which I prefer. It's easier for me. I get used to it. Ike is the one to blame for me to start using temporal approach.
Yeah, I have to say, I think the temporal approach gives us the widest access to the incision. So
Yeah, it's
great.
more comfortable. Also, it's more friendly with your back and your neck. So once you have it, you pass the 3 ones. You start pulling the distal end of the suture, and then knot starts sliding. You can pull a little bit from the proximal. Here you have to do it more slowly because of the tissue. It's more fragile, and there you go. The knot slides or slips into the eye, and you can finish or correct your iris defect. I do it 3, then 3 passes, then two more knots or 2 more passes, and to lock them. And finally, I use a micro scissor to cut the suture. I'm not going to do it. The other 2. Take the grasper. So it's a micro scissor, and you can cut the ends inside the eye. You have it there and there. You can be, and you can pull them out, and you finish your knot nicely and sleek.
Amazing,
right?
man. Amazing.
And something key here. There you go. So here it is. And now I don't know if any comments from the panel. Ike.
Very
Yeah,
nice.
I think nicely done. I know it's hard to see the suture, of course, on video, and play it back on YouTube, of course. I recommend it, but you can see that really, I mean, these techniques are something that I think all of us can learn. Really, they can if we obey the principles of closed system surgery and instrumentation. But good job, Ponce. Nice work.
Thanks, Ike. Okay, so
Let's talk a little bit about weak
let's talk
sonula.
about weak
You know,
sonula.
Milton, it's getting late for Milton, and he's afraid to go to bed now. But let's just you know, we're going to talk a little bit about weak sonula. We have this, Ike. What can we say? You know, this is an invention from you, amazing tool to use in some kind of cases. So I would love you to introduce this segment while Jose Ramon it's putting it.
Okay, so I can just show a technique for dislocated or subluxed lenses. Now there are a variety of approaches. I mean, there's no one approach that is necessarily the only one, but you can see how this patient has a pretty significant dialysis. The first thing I want to talk about is where do we actually suture? Now, it's, you know, I'll talk about the human eye, but we have a few landmarks to use. We see here, we have the limbus. Of course, the limbus is obviously very well known. We have then the blue zone, and then we have the white zone behind the blue zone. The end of the blue zone basically matches up to the anterior trabecular meshwork. If we go 2 millimeters behind the blue zone, that should give you basically an approximation of where the zonules should be. This is perhaps a better approach than using the limbus, which is, you know, somewhat more variable. In a myopic eye, for example, the zonular plane will be farther back than in a hyperopic eye. But if you use the blue zone, you're always going to have the same position. I'm going to forward a little bit here, and of course, the capsular rexus is often challenging. But when you have a subluxed lens, number one, try to do the capsular rexus to center on the capsular bag, not on the pupil, not on the limbus, and make the capsular rexus follow the contour and the shape of the capsular bag. And using forceps and multiple incisions, these are all somewhat challenging. And again, this lens is perhaps a bit more challenging than some other lenses that you may see. Once we have this, then again, what I do is, and there's different approaches, you can use capsular retractors, which are very nice. These are different than the iris retractor, which I'm showing here, but they're specially designed for the capsular bag. But this is basically just showing you a technique using the capsular tension segment. And I'm preparing the bag for the segment by placing some iris hooks. Now I put the iris hooks here just to hold the bag in place. Sometimes the bag is moving around, and sometimes it's hard to get the segment inside the bag. This is some viscodissection. Next step, to inject viscoelastic to separate the capsule from the lens. And this will allow us to make enough room as you'll see now, to place the segment into the eye, which can go through a 2.2 millimeter incision. And this will basically act like a hanger, like a coat hanger. As you see here, we're going to move it in position. Now, this eyelet, the central eyelet, is sitting just a bit anterior to the main body, about 250 microns anterior. So use the Sinski gancho here to manipulate the segment in position here to be placed into the capsular bag. It's subtle, but you can see the segment is now in the bag. You can see the large 120-degree surface area protecting and inside the capsular equator. And then we will take the iris hooks and basically turn this upside down and place the segment through the iris hook upside down. This is the way we do it. And now we have it well secured, and we can remove the remaining iris hooks. And there we have it. We have the segment supporting the capsular bag. Now this is obviously a fairly subluxed bag. It's a soft lens. We can remove the lens with IA, and then we will then detach the segment from the hook. So this is in 2 steps. This hook, the segment acts like a retractor, as well as now we were going to suture it in place, enough viscoelastic. There really is no need to do vitrectomy in these cases. The vitreous stays back nicely, which is nice to protect from retinal issues. And we will then pass the needle. Now you can see we're passing the needle through the segment, which has been placed in the middle of the anterior chamber, using a docking needle through a 25 gauge needle through the groove that's made, again, 2 millimeters back from the scleral spur. That's one pass made through the eyelid, double arm suture. This is Gore-Tex. Nino-Prolene can be used, although we like Gore-Tex preferentially because it's more durable. And then we will pass the second here pass. There's the 25 gauge needle. We make it about 2 millimeters across from the first pass. You can see there. Go above the capsular bag and now dock the needle. I want you to realize that each step here is not difficult. Anybody can place a needle in the eye. Anyone can pass a suture through the eye, right? But piecing it together and imagining this before surgery and anticipating where things may be perhaps not exactly as planned is what helps here. Now you can see we can suture the Gore-Tex. I typically use a slip knot, and we can then tighten the tension down. I usually do put a capsular tension ring in as well. The ring provides more circumferential support for the bag. And then we basically can put the lens in and finalize the suture tension. And this is just one way to manage these dislocated cataracts. I like to use the capsular bag, and I find the segment along with the CTR provides the most versatility. Of course, the Sione ring could be used, but the Sione ring is not as versatile in my opinion. It usually is placed after the lens is removed. And is more traumatic to put in the capsular bag than a segment. So there you go. That is an approach using a segment for a more difficult sublux lens. And my
Thank you so much, Ike. Thank you so much.
Very
Let's
nice.
see what Jose Ramon is doing here.
Imagine that we already done all that. The Rexis, the Phaco, you have the CTS and the CTR inside the bag. So already had the Gore-Tex. We are using an 7V. It's more preferably to use the 8V, but it's fine. You have to make a Ponce's needle, the crook one. Try to straighten it as you saw in the video as much as you can. And we already had the prosthesis with a needle under the CTS, and I already made a prosthesis in front of it. So as I said, you have to plan everything before doing it, and you have to be sure where you are gonna do all your steps so you can do it before and don't be hasted when you're trying to do it. So I already made the incision here. Remember, this tissue is really bad. So I'm the first needle is captured through the hole of the CTS and then docked into the needle. I'm using a bigger needle. Don't use this at home because it's going to be messy. So you pass it through and try to dock it and extract it from the eye. Sorry, there's a lot of bubbles. Let me just take it out. So that's
just one thing I would mention is that you know, as opposed to iris suturing, where a curved needle is helpful, in this case, I find a straight needle is preferred because we want to go across the AC. We don't have to go back up into the cornea. We want to go into the sclera. And a straight needle is easier to control than a curved needle, which can sometimes cause traction on the iris or on the cornea when you're passing it through. So one little tip is I often will straighten the needle out to make it straight.
Okay.
Yeah, make it more straight as possible. Yeah, it's a great tip. So I'm trying to do it again. Sorry, it's different here. The needle is not helping. Sometimes when you have a good
And one thing I will say, Ponce, as you mentioned, I mean, it's good to have a needle, a hypodermic needle that matches the suture needle.
yeah, that matches the suture.
And
exactly.
in this case, we made it a bit difficult for you because this hypodermic needle is larger than your needle. So it's going to be hard to dock it, but you can show at least the approach. We will understand why it'll be difficult for you. But for the Gore-Tex suture, a 25 gauge matches nicely. For using 9.0, typically we use a 26 gauge.
Que sea del
9.0
mismo
is
grueso
like
que
a
la sutura.
CTC6 needle. And if you're using a 10.0, then a 27 gauge often is enough. So just make sure you know the needle you're using and what matches it. Do it outside the eye
Es
to
mucho
practice
más
it before you
grande
go
que
in.
¿Tienes una aguja más pequeña, Ivo?
¿Una qué?
Una aguja de insulina de las 22 que
Me fijo.
I just sent Ivo to try to get me a smaller hypodermic needle.
Let's see.
You have it?
Está Alex
So
por ahí?
I'm kind of using something else I have at hand, which is a micro forceps. So it can be done. So you pass the first one through the loop. Of the CTS.
And that is another option, by the way, as you show, Ponce, you can use a micro forceps to grab the suture rather than docking it like you showed.
Exactly. Yeah, it's kind of easier. I prefer it that way, and I've been doing it like that. And then you pass the other half of the suture through the same paracentesis, but outside the loop, as you saw in the video, and you can tie it outside the eye. And
Una aguja y-
it's fine, Ivo. No worries.
No, yeah. The thing is, so people understand all the dexterity, all the, all the small movements you need to do. You can perfectly do it in an artificial eye. So in the moment you go to a human eye, you know what to do. You know how it will behave. I think this is amazing, actually.
It's incredible.
For matters of time, we're finishing this one, and we're gonna show a little bit now about a Yamane technique. Again, guys, we wanted to go fast, and we want to go in many different things, so we understand that the environment and everything we have, can help us become very, very good surgeons and keep learning, right? You always, I'm sure you always have something new you can learn. And the IOL fixation techniques are very, very important, and they're, everybody wants to do them. So now, as you can see me there in this camera, I'm gonna go fast, and I already did a lot of the job. I have to thank one of my great friends, Dr. Noel Rivero, who has an amazing way to teach a Yamane technique. Also, Ike, it's very expert, and the other panelists about Yamane. And let's see if we can change what I'm seeing in the ingenuity, please, to the audiovisual team, so I can show a little bit what happened here and what you can see. Let's see if we can zoom out a little bit, and you can see, please, the image in the. You can move forward, okay? So there you go. There is a lot of stuff happening there, and let's see if
Ivo,
you
can we
see.
show quickly this camera just to?
I'm sorry.
Can we show a little example here?
Oh, sure. Let's go back a little bit to the other camera.
Just this is what's going to happen if you don't do a correct paracentesis. The strands of the cornea, the suture can be holded into or entangled with the cornea fibers, and you won't be able to go through. And this is going to happen. So you have to be careful and also be remember every time you do this that you have to pass it through a paracentesis, not through the cornea, because this can happen, and then you're doomed. That's it.
Thank you, thank you. Okay, let's come back here. And I wanted to show you, with a very low zoom about what I did and how much you can learn from a Yamane technique here. And then when you go to the human eye, you are mastering many things. Dr. Rivero, a good friend, has a saying that it's Yamane, it's simple, but there is so many secrets you need to master. There's at least 10 to 12 tips that if you master, everything is going to come ready. So I want you to see real quick. First of all, of course, it's an aphakic eye in where I have here the main incision. Okay, I have a 3-piece IOL entering with this aptic outside the main incision. What I did is I did an imaginary marcation, a perpendicular. Then I draw a line here with the main incision, and then I do an outward perpendicular, and I mark that. Then that's 2 millimeters from the limbus. Okay, then 2 millimeters here up and here down. Why? Because we want to do with the needles. You can see the needles, they're already there. Here's one. Here's no. I have a 27 gauge. There's other people that like, well, I would love to know what do you think? Which one do you use? There are people that they use a 30 gauge, but with thin walls. But that changes a lot. There's a lot of also different, let's go back to the anterior chamber and see what's going on there. But there's people that prefer different types of IOL, especially for how the optics behave. What I did already, so I don't want to spend a lot of time doing it, but I can do it again, is I put the optic inside the needle. I already did it in the first one, okay? So that's one of the important things you need to master. There's many different secrets, and we're probably gonna invite Yamane and have Ike and many other people to talk about this technique for what, 1.5 hours? But we wanted to show you what this eye is capable of and how much we can, teach. So I'm gonna go very fast with this amazing micrograsper here. So I'm going to try to do again, the maneuver. But Ike, what about those 7 to 8 to 10 tips to do a Yamane?
Well,
which are they?
Yeah, I mean, I think you're absolutely right. Yamane is a beautiful technique and it's simplistic in its way, but there are many little subtle things that are important to remember. And I think the first thing is, of course, having the right needle matching the haptics. And you said earlier that really ideally a thin-walled 30 gauge is ideal. If not, a 27 gauge can work, and it's best to try it outside the eye. Second point is the landmarks. Positioning the landmarks are important. We typically go 2.5 millimeters back from the limbus and try to make a 2 millimeter scleral tunnel and make sure that they are opposite from each other. Thirdly, as you're showing, a micro instrument is very helpful, like a micro tying forceps, to grab the haptic to place it within the needle. And this is helpful. Notice as well that I like to make the fixation points. In this case, for example, as you have it here, about 8 o'clock and 2 o'clock, a bit tangential. I don't make it typically at 3 and 9 o'clock, for example, if you're looking at this view here. This is better because the trailing haptic is what usually gives people the most trouble. And having the second fixation a bit farther away from the incision is helpful to avoid the twisting of the haptic. It does help to keep the haptic in the first needle. Don't pull the needle out until you have the second haptic docked as well. And then, finally, using, of course, a cautery to melt the end is helpful. The biggest challenges people have is, as you're going to probably show, is putting the trailing haptic in. And this is where, again, ensuring that we have the right angle is important. So right now, for example, your incision is basically made about 90 degrees away from the fixation point. I typically make it more than 90 degrees away because then we have a better angle to get the needle into the haptic into the needle. A subtle point, but just compare where your paracentesis is and where your incision is going to be. This helps you to kind of plan your angulation. It does help to have an AC maintainer, I will mention, or a pars plana maintainer, because the globe can get very soft. Often these eyes are vitrectomized, and so it is helpful to have some infusion in the eye, because otherwise the globe is collapsing, the cornea is lots of stria on it, and these are all issues there. But I want to ask Milton and Luz Marina, of course, to give their thoughts.
Please, Luz.
Well, I strongly agree with the concepts you're saying, and the localization of where you make the prostheses. I think it's a clue. It's a clue so that you could properly manage all the angulation of the instruments. That's very important, not just in this type of surgery, but in phaco surgery as well, when you're using your left hand as a second instrument.
Okay,
Well,
guys.
May I?
Yes, sure.
Because I just want to be on, because I just want to go on the opposite side. I love the technique, but I have some considerations regarding this technique. I think it takes some surgeries for you to master it. I would say about 10 or more surgeries. And so many surgeons, they don't perform, I would say, 3 scleral fixations a year. So I would say that this is not a simple technique. It's very straightforward, very fast, but you have to train it. So I think for the regular surgeon who performs up to, I would say, 3 or 4 scleral fixations a year, this can be deceiving. Maybe he goes through Yamane technique because the perception is that it is quite easy and it's faster, but I would say it's not. I think it's a very good technique for a surgeon that performs a nice amount of scleral fixations a year. And I would suggest you keep on with the traditional scleral fixation with Hoffman pockets. Hello?
Hello?
Ivo, we're not listening.
You're on mute, Ivo.
We're not listening to.
Okay, so yes, no.
Good.
Can you hear me now?
Good.
Yeah.
Yes, perfect.
Oh,
Yeah,
sorry,
perfect.
sorry, guys. So just to finish, then again, everything about education and about transfers of skills and knowledge. And there is a lot of stuff about the cognitive and constructivism theories, but I think we're talking a lot about that, about the principles, about concepts, about how we are wired in a way to learn different things. But there is also amazing thing about what's happening right here. Sorry, guys, about sharing. We are right here with 3 amazing experts in the correct environment, learning a lot, having social interaction, and that's the best way to learn. So we want to thank everybody. We want to invite you for next week. We're going to talk about, we're going to have a workshop for toric IOLs with technology, without technology. I will believe that everybody will, finish putting torics to everybody in a good way. We have a last question to the audience. We also, we have a course about all this content. So everybody who wants to learn a little bit more, they can take a QR picture of the QR. So we want to ask you, in a setting like this, do you think you can learn to manage complications? Yes, no, maybe. Okay. We want to thank everybody again for your time. It was an honor. I want to thank especially Dr. Milton Yogi, who was so kind, to organize this with me, to invite Ike, Luz Marina, also part of the team, was so happy. And, people saying almost in 100% that yes, absolutely, and maybe they can learn in an environment like this. Those 30% who say maybe, well, maybe we can convince you in the future. Thanks all the people that was with us. This is very late for Argentina, Brazil, Chile, Uruguay, and I will love a few words. Also, to thank Sir Ramon did an amazing job,
you,
had the
Ike.
most complicated stuff today.
Thanks,
So
everyone.
starting with Milton, then Luz Marina, then Ike, I will love some close comments.
Well, first I would like to thank the organization of Vivo and his colleagues for this excellent event. I would like to make a small comment from what Ike said and Luz Marina also said. She mentioned about mindfulness. I remember that, and Ike telling that all surgeons are I would say equal, because I do practice mindfulness. It's a form of meditation. And yesterday I had very tough cases during the morning in my surgeries, and at night to unwind my mind, I practice a little bit of meditation with mindfulness. So it's a suggestion I make to all the surgeons who deal with complex cases. I also would like to remind that I sent through the chat the WeTransfer file for the 2 videos I would present today, but unfortunately there was no time, but you can download them. And again, thank you all.
Thank you, Milton. It was an honor to have you. Luz Marina.
Okay, thank you so much for the invitation. Thank you for all my panelists that are here with me, for Ivo, Ophthalmo University team, everybody. And I just wanted to say that I think it's very important to keep on shaping the technique, because when you make a good technique, as I said before also, when you do simple things with good technique, you will be allowed yourself to do complex things. So the technique is very important. You have to keep it up with a good technique, make it persevere, one step, the other step, until you complete the whole set.
Thank you very much, Luz Marina. It's such a pleasure to have you here always. Ike, thank you so much for your time, man, today.
Oh, I mean, hey, this is for me the fuel of my professional life. I mean, to be with you all here. I mean, Milton and Luz Marina, just classy people, so thoughtful. They just shared so many great points, and so much humility. I mean, people can show off, but you see the humility we have amongst the panelists and the willingness to share. I mean, it just makes me just love my profession and my colleagues so much. That's just what we do, right? I mean, forget the surgeries. I mean, look at the beautiful people we have amongst us to do this great work. And God's work. It's really amazing. It's really amazing. I feel honored to be part of it. Ivo and Jose, I mean, you guys, I mean, you had the heat on and you performed extremely well. It's amazing to show these techniques. And thank you to Bionico. I mean, I think the artificial eyes have made a huge difference for training. I really recommend it to training programs and those learning, even seasoned surgeons who are learning techniques like this. It's very, very helpful to just practice where your hands should be and everything else. Eva, I'm just amazed at the people you have you brought together for Ophthalmo University and Phaco Mentors. I mean, like, I don't know any other program like this in the world, and the dedication you have and the volunteers you have and the people behind this project, that people that are nameless that I know are involved in this. And I thank them for that, because it's really amazing and the beauty to see that. Most of all, your passion and love, just show it. It just shows it, right? So wishing everybody so much happiness and safety and security, and want to see everybody very soon. This makes me miss all the times we had in person, and it makes me regret that I didn't spend maybe one more minute up all night to hang out with you, even though we spent many late nights together. We know that. Thank you. Gracias.
Thank you.
Oh, we love you, man. We simply love you. You know that. Thank you for your time. It's such a pleasure. The willingness to share from you, it's incredible. Guys, we don't want to take more time. We want to have you next Wednesday with us. Yamane, just finish last words to finish, but this was amazing. I think this was historic, right?
Yeah, completely historic. Incredible.
So, well, Cesar is here. Thank you so much. Jorge also translating this big community, translating to Spanish, to Portuguese. We're so happy. And these guys are great surgeons, right? Translating to other colleagues. It's great. So go to sleep.
And free of charge.
Good luck, Milton, when you finish this. And, hope to have you here soon, all of you.
See you guys.
Thank you.
Bye.